This is Namitha Setmotha for NEJM Catalyst. Today, I am speaking with Dr. Ghazala Sharieff, Corporate Executive Vice President and Chief Medical and Operations Officer of Acute Care at Scripps Health, a health system based in San Diego, California. Dr. Sharieff and her team have designed and implemented a system-wide effort to realize operational excellence called the 6Rs. These 6 integrated initiatives improve both clinical care and operating margin. During our conversation today, Dr. Sharieff and I will talk about the why, the what, and the how these 6Rs were designed and scaled in hopes that our NEJM Catalyst listeners can apply the lessons learned at Scripps to their own respective institutions. Ghazala, thank you for speaking with NEJM Catalyst today.
Well, thanks for having me. I'm excited to share the work that we've been doing.
Let's start with context. Tell us a little bit about Scripps Health and the initial need to focus on improving clinical and operating margin to begin with.
Yeah, so Scripps Health, we have 5 hospitals in our system. We have 30 ambulatory clinics. And so we have close to 20,000 employees. That's including employees, staff, physicians, and volunteers. So that's a lot of people that we need to reach on the front lines. And that's really what this initiative was about.
Why the clinical and were there clinical and operating margin issues that made you think about doing this? Where did it come from, the need? What was the problem you were trying to solve?
Yeah, that's such a good question. The problem we're trying to solve was we have initiatives that come from the executive team that are blessed by the board. The question was, how do we make that impactful to the people actually doing the work on the front lines? Because we know what the objectives are as an executive team, and so do the regional chief executives and the physician operating executives that we have. But how do we make it meaningful so that people doing the work every single day know what the focus should be? Because there's so many priorities right now that they need to know what their work is about. And we thought, how do we engage them? How do we make this simple? And that's how this initiative was born, really by that concept of, I want to walk on the floor and go, what's your 6R that you're working on today?
Tell us what those 6Rs are.
They're actually really basic, and I bet all of you are probably working on all of them at the same time. But the first R started with retaining staff. I think we all know how important that is to have that environment where people want to stay in your culture. And but also through COVID, there are a lot of people that took on traveler jobs and went away. Now we have those people coming back, and we wanted to re-ingrain them into our culture and what makes us special. We also had a lot of new people to the organization, and I was actually worried about the loss of organizational memory, right? People know why we're here, but you're new to the organization. Maybe you've come from someplace else. And so we want to know, how are we going to retain staff and how do we learn from each other? And we can talk more about that one because I think it's a really important one. So one is retain staff. The second one was repatriating our patients. So what that means is that if you've chosen Scripps or whatever your healthcare organization is to get your care and you land up in a different emergency department because the paramedics took you there, how do we bring you back home? Not only is the right thing to do, right, because you chose us, but it also has a financial impact, right? Because if we're paying out of network, it was literally costing us millions of dollars by not having a better process in place for bringing our patients back home. So that's 2 right there, repatriation. That leads to the next one, which is reducing cost, which is exactly that, right? If I'm paying a lot out of network, that's just one example of how we can reduce cost. The next one is reducing length of stay. Many of us are paid by diagnostic related group, DRGs, right? Those are the payments. So the faster that we can treat people properly with quality care, but the faster that we can get them discharged and onto a better place rather than staying in the hospital, the better that is financially and for the patients. So that's reducing length of stay, raising revenue through philanthropy, so raising dollars. That's something everybody needs to do. And the way to do that is by grateful patients, right? If we do the right thing on patient experience, people are more likely to donate to us. And the last one was an interesting one. We wanted people to think differently and outside the box. Just because you did this the same way for 25 years doesn't mean it's the right thing to do. So the 6R is reassess and reimagine. And we have examples of that as well. And giving you the freedom at the front line to come to us with new ideas that might fit into the other 5 Rs, for example. So 6 Rs, simple.
You mentioned that the target audience for these 6Rs is actually the front line, people who are taking care of patients, working in the ambulatory clinic. I have to be honest, they are very straightforward and very simple and meaningful. And are they motivating enough? They aren't necessarily the world's most inspiring goals. I don't hear a lot in there about anything related directly to patient care. How did you make that trade-off between something that was simple and meaningful and tied very concretely to what the CEO and the executive team needed and wanted to do, with the need for something that's a little bit more North Star, pie in the sky feeling?
Yeah, so we have objectives that are that's separate from this for quality, right? We all have our hospital-acquired condition reduction programs and hospital readmission reduction work and patient experience. That's separate. Those are board quality metrics. So we already were doing that work. So I don't want it to seem like we're distracting from that at all. That's first and foremost is patient care. But if you think about it from the front line, why would I want to open up a bed so that I get another patient in from another hospital when I'm perfectly happily taking care of the patient that I already have? It's a lot of work to turn over a bed, right? Think about that just from a practical perspective. And so we wanted to make it meaningful to that nurse that's in charge of discharging the patient, in a timely fashion and opening up a bed. Why do I want to open up a bed? Because you're bringing a patient back home, and that's what repatriation means. So that's a simple example of that. The other one is I think we have to empower our frontline staffs. A lot of times things come down from administration and this is what you have to do. But instead we're saying, you guys go out there and tell us what to do. So one of the initiatives under Reassess and Reimagine was what we call the MOVE initiative. That is when we get patients up and out of bed 3 times a day. Well, that may sound like a no-brainer, right? We should be doing that. But we figured out what are the barriers to getting patients out of bed. It turned out it was documentation. If you look in, I'm not going to name names, but we have a very good EMR. But my goodness, and I was in the hospital. Some of you know I had a spinal cord injury and I was in the hospital myself. For them to get me out of bed was no small feat. That put me up in a sling and lift me over when I'm in a bunch of different medications. But when I saw the amount of documentation that the nursing staff and the physical therapists had to do, it was a lot. So I wouldn't get myself out of bed if I had to do all that documenting, to be honest. And so they went back and they looked at it and tried to make things a lot more simple. And now we have this initiative that we're live with at 80% of our units right now, getting patients up and out of bed 3 times a day. That may sound like, well, why wouldn't you do it? But I told you the barrier. The advantages to that tie into all the other stuff we just talked about. If you get out of bed, you're more likely to not fall, right? So that's one of the things we all work on is reducing falls. 2, less likely to get pressure ulcers, less likely to get pneumonias, less likely to get blood clots, which are all metrics that are tracked under hospital-acquired conditions. So you can see how it relates back to the core stuff that we have to do, but by doing things at the bedside. And so we had to explain that to the staff as well. This is why we want you to encourage your patients to get up, because you can solve problems downstream. And what we found is by getting them up out of bed, sometimes they don't even have to go to a skilled nursing facility in between, right? Because we get them mobile and ready they don't get deconditioned. And so there's a lot of reasons, but that was around the 6-1 Reassess and Reimagine. But guess what? It tied into reducing length of stay because people were up and about, right? We reduced cost, right? And we also probably reduced readmissions, right? Because people are up and about and not getting the pneumonias and returning in 30 days. So simple things that may sound simple turn into more meaningful conversations later.
Of course. And then you have a grateful patient who may turn around and help raise money.
Exactly. There you go.
It is helpful to hear this because it's the use cases and the stories around the 6 R's and the whys that are just as important as those 6. They enable a communication and a shared taxonomy amongst all of the 20,000 employees at Scripps. So it's not really what I'm hearing from you. It's not nurse, go work to reduce length of stay today. It's how can we help you get your patient out of bed that then have some of these downstream effects. You shared the example about this MOVE initiative. What are some other projects or initiatives where the 6 R's have motivated to make change at the front line? And just like you mentioned earlier, what were some of those challenges?
One of the other initiatives we came from our pharmacy team was patients who had to stay in the hospital for IV medications, IV Vanco, for example. And there's a new drug that you give, for over a shorter amount of time. I think it's 48 hours. You give a couple doses in-house, and then they come back as an outpatient. Well, first of all, it's nicer for the patients to do it that way than to stay in the hospital for 4 to 6 weeks, endocarditis, for example.
Yep.
And so that alone, and this is a pilot with 17 patients that just started, $500,000 in savings. And the way we calculated that is based on length of stay. So if you're in the hospital for 4 to 6 weeks for IV medications, that's tying up a hospital bed for that amount of time, where I could be doing how many more surgeries and getting more people into the bed, decompressing the emergency department. That came from the pharmacy team. We said, go look for opportunities. Yeah, right. And so they worked, and they're so excited when they get to come to the board. And so I invite them to our board meeting to say, hey, why don't you tell us what you're doing out in the field? And that's taken on more. And I just briefed today, actually, with a presentation about repatriation that's coming, and the length of stay and things like that. And like, oh, let's fit it into the 6 R's. And we can tell the board. And as they're going through their checklist, like, oh my God, we hit all the 6 R's. We're reassessing and reimagining, and we're reducing costs. And so it's fun for them to kind of put in their own buckets that way. The other one we did was leased beds. I think many of us had to do this during COVID. We just could not get patients into the skilled nursing facilities. So we leased some beds of our own, a different facility, so that we could increase throughput. By that alone, we saved well over 14,000 bed days. Again, when you back to the DRGs, the diagnostic related groups, when you get paid a flat amount, the faster we can get these patients out who are ready to go to a skilled nursing facility, the better. And so by leasing our own beds, we don't have to wait for some of the other facilities to open up, right? And it's simple. That's what a simple idea that is. That came from our front line. I would never have thought about that by myself. They said, we need to do this. And we're like, okay, it's a little risky because you're guaranteeing bed payment for beds you may not need right now. And I was a little worried about that financially. Turns out we're using the beds. So there you go.
For the skeptics out there,
yes,
how is this effort different from the strategic roadmaps and priorities that guide the work of so many of the health systems that are out there, including my own?
All right, I challenge you to go to the front line and you ask them what their main focus is for the year. That's what we found when we went to the front lines, even the supervisors say, hey, what are we supposed to be working on this year? They came back with, well, let's reduce, the infections and patient experience. I'm like, what else? No one. There's no common language. And that was our gap. So not everybody's going to work on every one of these 6 R's, like our central transfer center is not going to be working on some of these things. Maybe they are, but your focus, repatriation, bring those patients home. And ultimately, yes, they reduce costs and all that. So everybody may have a little different take on what their R is going to be. But even our finance team, when they report out on a monthly basis, they kind of put it under these, this is what we're doing to raise revenue. This is what we're doing to reduce cost. And so there's a common language. And I think maybe that's what's most important. And I'm not guaranteed that all 20,000 people know what the 6 R's are, because that's impossible. But the main people that know, and the leaders are out there. And we have a little visual that my executive assistant made around. It's got a little wheel. It's got all the 6 R's on it. And so it's fun when we get out and around and we see the posters up, say, there's the 6 R's, and they'll talk about it in their huddles. So it's just a way to have a common language. I think that's most important, and something catchy that's easy. Otherwise, people are not going to know what you're working. And that's a gap across many, many organizations. They do not know what they're supposed to be focused on.
So what's next? Are we going to have a 7th R? Are we going to solve repatriation and go down to 5? What's next?
I don't think we're ever going to get rid of the 6, because they're going to go on for a long time, because repatriation is always going to be there, reducing costs, especially in the environment we're in right now. It's even more important that we focus on these. I added a separate R. It's funny you asked me that. Responsiveness, and it's completely separate from this. And it's interesting that our HR team decided to use their own 3 R's. One is, respect, right? Respond, react. So they have their own 3 R's around, how to manage some of this. And I think those are really good R's, because responsiveness is important as leaders, right? When I send an email and somebody doesn't respond to me, then I'm wondering, did they get the email? Did they not get the email? At least acknowledge. And so that's a leadership thing which I think is really important, not only for executives, but for each other, supervisors, managers, right? And also for patients. If I say I'm going to follow up with you tomorrow, even if you don't have the answer, you better follow up tomorrow and tell you that, versus having the patients wait. So we've got an initiative right now around calling Getting to Yes, which involves how do we get to that yes faster for our patients, versus saying, you saying, can you get me in tomorrow? And we start with no, but how about we would love to get you in. How about this instead? It's changing the language of no from the beginning, from that phone call. So you can only do that if you're responsive to your patients. And so you can see how it all kind of crisscrosses across the organization.
And ultimately leads to the culture change that
Mhm.
will get us to a place where we all need to be, which is improved care for our patients and the populations that we serve.
Right?
Thank you so much for a wonderful conversation, and we thank you for joining us today.
Thanks for having me.